Assalamu alaikum. Now, now I would like to discuss about primary versus secondary adrenal insufficiency. Start with my intro where you can hear a heart sound. Can you tell me the name of this sound? Okay, if you know, then put it in the comment box. Okay, before jumping into the topic, I would like to see a stem. A 13-year-old woman comes to the office. Why? Due to worsening fatigue, abdominal pain for the last month since the birth of the child. She had an emergency cesarean delivery complicated by significant hemorrhage that required transfusion of multiple units of blood. So during cesarean section, multiple unit of blood needed. So PPH, postpartum hemorrhage, actually happened. So and in the consequence, what happened? In the consequence, the mother is unable to breastfeed, and she has switched to formula feed for her infant. She also reports occasional dizziness when standing. Temperature is normal, blood pressure low, pulse 96, skin dry, abdomen is non-tender to palpation, and the patient has sparse axillary and pubic hair. These patients has sparse axillary and pubic hair. The remainder of the examination is unremarkable. What is my likely diagnosis? I think that it is Sheehan syndrome, which is a secondary adrenal insufficiency, and the features in secondary adrenal insufficiency, like in secondary adrenal insufficiency, cortisol is low, ACTH is low, serum sodium is low, and there is normal potassium. Because aldosterone is normal, so we know that aldosterone causes increased sodium and decreased potassium ion. So aldosterone will retain sodium and excrete potassium ion. So on that perspective, you may think that there may be hyperkalemia, but in secondary adrenal insufficiency, aldosterone is normal, so potassium is normal. Okay, first, primary versus secondary adrenal insufficiency. In primary adrenal insufficiency, there is destruction of the bilateral adrenal cortex, and in secondary, there is disruption of the hypothalamic pituitary axis. In primary adrenal insufficiency, disruption or destruction of the bilateral adrenal cortex, and the possibility of losses are autoimmune adrenalitis, infection, and malignancy. Autoimmune adrenalitis, infection, and malignancy. And the secondary adrenal insufficiency, there may be chronic glucocorticoid therapy, infiltrative use, chronic glucocorticoid therapy, infiltrative use, and ischemia of the anteropituitary gland. In primary, cortisol is low, ACTH is high, aldo is low too. So cortisol is low, aldo is low, and ACTH is high. But in secondary, aldo is normal, cortisol is low, ACTH is low too. And how you can differentiate between primary versus secondary adrenal insufficiency? In primary adrenal insufficiency, there is more severe symptom: hypovolemia, hyperkalemia, hyponatremia. So aldo low, sodium is low, and potassium is higher, hyperkalemia, and there will be hyperpigmentation. But in secondary adrenal insufficiency, there is less severe symptom. There may be euvolemia and minimal electrolyte pigment and the pigmentation. This word is very high. Pigmentation. No pigmentation in secondary. So secondary there is no pigmentation. Primary there is pigmentation. So it is Sheehan syndrome. Anterpituitary infraction in the setting of the PPH. Okay, the most important thing in adrenal insufficiency is characterized by cortisol deficiency. It presents with GI symptoms, loss of vascular tone like orthostatic hypertension. In addition, because cortisol, look at this picture, cortisol acts as an inhibitor of corticotropin releasing hormone and ADH release. If there is no cortisol, if there is low cortisol, then what will happen? If there is low cortisol, there will be high CRH and high ADH release, high CRH and high ADH release, and these corticotropin releasing hormone is stimulating more and more to the pituitary gland to release more and more ACTH, and the cortic more and more ACTH, and if cortisol does not inhibit the ACTH, then if cortisol does not inhibit the corticotropin releasing hormone ADH release and ACTH release, then more and more ADH is released. The syndrome of inappropriate ADH will lead to hyponatremia. So why there is low sodium? Due to these inappropriately increased antidiuretic hormone. So low cortisol, the decreased cortisol in adrenal insufficiency often leads to SIADH with hyponatremia. SIADH with hyponatremia. So as ADH release is, when there is more cortisol, it give negative impact. If there is no cortisol, there is no negative impact on the ADH, no negative impact on the ADH secretion, then the more mm, and more ADH is released, and this causing hyponatremia. Although these features occur in both primary and secondary pituitary or secondary or hypothalamic or tertiary adrenal insufficiency. Further manifestation differ on the site of hormone deficiency. In primary adrenal insufficiency like Addison's disease, destruction of the adrenal cortex, ACA, there is destruction of the adrenal cortex. So cortisol is low, ACTH is high. Cortisol is low and ACTH is high, and the patients develops hyperpigmentation. Co-secretion of melanocyte-stimulating hormone with ACTH. Aldosterone deficiency leads to hyperkalemia, salt wasting, volume contraction, and hypokalemia. In central adrenal insufficiency, like in Sheehan syndrome, it results from disease of the pituitary of the hypothalamus lead to deficiency. So in Sheehan, there is no ACTH, there is deficiency of the ACTH, so skin hyperpigmentation does not occur because there is no co-secretion of MSH with ACTH, because there is no ACTH, so there is no way of co-secreting MSH because the adrenal cortex remain intact. In central adrenal cortex remain intact, then aldosterone synthesis required by renin-angiotensin aldosterone system is unaffected, so aldosterone synthesis remain unaffected and potassium level is normal. Hypotension can occur typically mild. Hypotension can occur typically mild. So this is all about the primary versus secondary adrenal insufficiency. Hope you enjoyed.